Well, thanks, and I think that it's really exciting to hear the update about SCAD because I think this allows many more people to have access to participation in research. Canada's covered, and now more of the US is covered. I wanted to talk about, I don't have any new disclosures, that this is just some pictures of our team, but it takes a village to particularly address and better understand a disease for which new things seem to happen every day. And the one thing that this allowed me is on one of our projects, so in the lower right, you see that's my daughter who actually participated in two of our publications. She's a psychologist, so is our psychology expertise. But taking a step back, this was our original study population. So when this all started, this was around the time that Dr. Saul was looking at SCAD as well. We were already looking at a retrospective. And in 2009, a group of SCAD patients came together on Women Heart, the National Coalition for Women with Heart Disease online community for women with heart disease. This was sort of coordinated and started by Catherine Leon, who you will hear from. But if you think about an academic medical center trying to figure out how actually to study a group of individuals who are very eager, but for whom you had no location, no real name, no email address, and how do you capture that? So actually, we took a couple of years to really figure out how we might leverage this really unique resource of eager patients who wanted somebody to be looking at their condition. We did this, kind of long story short, we sent out a brief announcement. We didn't send it out, it was actually posted on the online website. We decided in a very unscientific and unrandomized way, because this was a feasibility study, to take the first 12 that got all their records in. So it was really, can we study in this remote, asynchronous, virtual registry way? So what we showed is that we could do that. It was a lot of work. You can imagine trying to get angiograms, original angiogram images. Maybe it's easier in Canada, but in the US, getting images from another hospital is talking to the little lady in the basement of the records, probably 4 little ladies and a man, and then them telling you it's lost 3 times, but it's really there, they just don't want to look for it. So we learned a lot from that 12 patients. We put together, this is our first poster. Around the time that we were ready to sort of publish that first 12, though, we had talked with a reporter at Wall Street Journal who thought this story of patient-initiated research was really cool and decided to feature it. And so that really helped, too, with raising awareness of what we were doing. This was our little study, which was sent back 4 times for review because they kept saying, well, you can't say anything about SCAD with 12 patients. And we said, of course, they're bigger series, but we have shown a new way to do research on a rare disease population. So how we describe it is a little bit of a poor man's multi-center registry. SCAD is perhaps a richer man's because there's a lot of people who actually have sites. But when we started this was a way to bring and look at the records of individuals. But we realized, most of the people that I enroll in clinical trials at Mayo Clinic, they've been seen at Mayo Clinic. Somebody's done a history and physical at Mayo Clinic. They've asked those questions. So one of the things that even reviewing outside records, you can't get that full story arc of a disease. What was the patient really feeling? And perhaps what's missing from those records that were sent. Was there another angiogram? Was there another infarct? So we asked for a patient narrative, which has actually been really helpful and I think very gratifying. Some individuals put 4 bullet points, that's their disease narrative. Others have sent us 10 pages of single-space typed disease narrative. And we love all of it because that's an added insight about the effect. We have continued because we've got great patient engagement as well. So our current update, so we've enrolled a little over 1,150 patients. Those are the ones, then we have about 100 in process. Those are angiograms that we have. People have submitted them. We just haven't gotten through looking at them. So literally my colleagues, the two colleagues, Patty Best and Rajiv Gulati, have looked at literally thousands of angiograms to get to this point. We have questionnaires that we send that are both retrospective and prospective, and I told you about the narrative. So what this has allowed us is our clinical practice has grown, much like if you become known for doing the work, there's more patients coming, and that allows us some additional things. We've got some prospective studies looking at echo and microvascular disease. We have, inevitably, because these questionnaires were designed 10 years ago and a lot has happened, so you said, darn, I asked about migraine, but we didn't ask about aura. So we have a mechanism to be able to send follow-up questionnaires to answer future and past questions and refine, because so much of a registry is just hypothesis generating. It actually raises more questions about things and observations than it does answer questions. And I think that is the crowdsourcing of the information is a strength. The fact that we still need to test these in clinical trials altogether is that next wave in the future. So I wanted to give you a brief overview of what we're doing on the net. So we have the registry, and then at the same time we set it up a DNA biobank. That is run by my colleague, Dr. Tim Olson. And so, the idea, we started hearing stories about multiple family members having either SCAD or aneurysms or dissections or people, and so we thought, well, maybe there's something genetic. So we are collecting DNA from patients and their parents and any affected relatives. And so we've collected the DNA, and as we have gotten funding, we have not had funding, obviously, to do whole exome sequencing on all of these samples because we have almost 1,000 of them. But that is one of the sources where we're looking to, because we think that there's a lot of opportunity, particularly because we have the parent trios, which we think are the richest, because if you have DNA from both the patient and both their parents. Now, I say parents because so many of these individuals are younger and their parents are still living, and so this will provide us some additional information. So we've got folks from all over the U.S., all over the world, and that is one thing, although as the European and Australian and Asian SCAD registries have grown, we have fewer who are signing up for our registry, which is a good thing. I think it's more straightforward to stay. But this has allowed continued recruitment because you do not have to come, you can send everything in electronically or by mail. So this is my colleague, Dr. Olson, and his PhD student who's working on this as well. So we covered this yesterday, but we were able to, with this multinational DNA study, which was genome-wide association testing, we're able to provide a large number of samples to be analyzed. But when the reviewers called back and said, oh, this is all because of the crossover with FMD, and you probably we were able to actually provide an additional analysis because we had the numbers. I will tell you that when Dr. Olson and I started talking about having a DNA biobank, we actually thought maybe we'd have 100 patients, so we were thinking about whole exome sequencing, which is the kind of DNA testing you do when you have small numbers. And we've done that on about 150 patients. We never envisioned that we'd have over 500, which allows us to start thinking about the genome-wide association testing. So, update on some of the active projects. So we're looking, as are all of us here, looking at what are some of can we tell anything from the angiogram that might predict future SCAD or help us understand SCAD versus non-SCAD. Looking at these associations, in my first talk I talked about how there are case reports saying that somebody had SCAD with something else all over the place. A few of them have risen to the fore. I mean, obviously FMD, migraines appears to, but there are others that maybe there's a couple of cases, but they keep popping up in the literature. And we now have enough cases we might be able to at least say, yeah, that seems to be a real association. Let's dig deeper versus not. Pregnancy-associated SCAD, looking at hormones, hopefully we can even do some prospective hormone sampling. And I think importantly, getting more men with SCAD in all of these registries. when we talk about biases in particular studies, one bias of registries in general is that it is people who survived, it is people who are willing, they're ones who are activated enough to find out about a course like this. One of the challenges with a study that started on a women's heart disease networking group is that I think fewer men are in our registry than are actually represented in the population. So we're always looking for more men with SCAD because it does appear to be sex and gender differences that are important. And if we think that SCAD is rare, it is rarer in men. So some of the things that we're looking at and going forward, as I said, Dr. Marisha Tweet has a project where we're looking at echo contrast after SCAD. My colleague, Dr. Rajiv Gulati, is looking at some metabolomics in acute SCAD. He's collecting blood and stool. We're looking at some additional multimodality imaging. These are mainly for patients who are coming to Mayo Clinic, but as part of, they're also part of the registry, and then trying to continue to look about the natural history of SCAD. So what we're looking for going forward, and we're always looking forward, is more collaborations. We're excited for iSCAD. We're excited to be here as part of Dr. Shaw's meeting. I think that the hot topics that have all been discussed here are things that we're trying to focus on more and try to sort that out. Not just, it really is the management of chest pain, and what can we do safely and thoughtfully and getting at the problem. And I certainly won't try to read off names, but I did want to show this slide because it really gives an idea of the multidisciplinary groups that are working on SCAD at Mayo Clinic, which includes cardiologists and medical geneticists and imagers and maternal fetal medicine folks, and many of our trainees as we hear that really is the future, is getting folks excited about studying this at their own institutions. And then when they leave Mayo Clinic to go and practice elsewhere, we have a whole new crop of individuals who are not going to be where we were 10 years ago. Thank you.
Thanks, Sharon. Maybe one burning question? Okay, we'll catch it up later.